Are there lessons that can possibly help? So first of all, everyone knows that the global burden of trauma falls with middle and low income countries. More than 90% of the trauma occurs there. And if you see here, in 2025, the mortality rate for your road vehicle accidents in Sri Lanka is about 3 times more than Australia. There's lots of reasons for it. One of the reasons is, of course, prevention. We're not going to focus on that particularly today, but it's easy to say that, you know, if you have driving intoxicated on your tuk-tuk, things go badly for him. If you make poor decisions about where you should drive, or if you break the road rules on poor roads, you're going to die. And your mortality rate, of course, will be much higher. So let's move to what they've asked me to really assess and having a look at. The first thing I think would be useful is actually data. It sounds boring, doesn't it? Data, right? But data is powerful. And the reason it's powerful is that data, you can take it, if you've got a nationwide, island-wide trauma registry, that's good. You can take that data to your government and your non-government sectors and say, this we do well, this we don't do so well. Why don't we shunt the money we've got into this area? And then after that, we can then look at the data again and say, yeah, you spent money well. It's changed. So data is surprisingly powerful because it shows those gaps. Now, you did have a pilot. I know it's almost a decade ago, but I'm talking about a full island-wide trauma registry. Next thing. Remember, we've only got 12 minutes. Mortality, morbidity meetings, part of that quality sort of stuff. So mortality, you think that'd be pretty easy. You know, you think everyone would do it. No, to do mortality and morbidity meetings well is hard. They need to be multidisciplinary, and they need to be not, you killed them with his help. So it needs to be, well, the system meant that we didn't have, rosters were wrong, everything else. So it's the system that you're looking at. If you do it well, if you do it properly and you do it regularly, it means that you'll be able to direct your education appropriately to the areas around your specific hospital that will make a difference to the quality of care. Now, the teaching hospital in Gaul, that seems to be the benchmark in Sri Lanka. You can tell me I'm wrong, but it seems to be the benchmark in Sri Lanka for mortality and morbidity meetings. But you don't do as many as I think you should. It's a relatively, certainly a cheap thing to do. Moving on. We're going to look at pre-hospital care. Now, everyone in this audience should know and be really proud of the Surya system, which I think this year has transported its 2 millionth patient. Mate, that's really good. And it's in all 9 provinces. And if you look at your transport times or your response times, they're bloody good. In fact, they're better than New South Wales, where I live. And for our highest category, category 1, category 2 patients, yours is better than ours. So tap yourself on the back. It's quite technically difficult to do, but do that. But of course, it doesn't show you the whole picture. There are things that can certainly be improved. The first one is that at this stage, still about 50% of your trauma patients actually are transported by tuk-tuks or 3-wheelers, okay? And there's about probably 20 to 25% that come in by ambulances. So although you've got a fantastic system, there's room to move. Also, your 1990 number, which you heard about this morning, great initiative, like our 000 number in Australia, it's great, except probably only 25% of the public are aware of it. Now, you do some good things with social media, like this. 999. So, but unfortunately, that hasn't been enough. You do face-to-face stuff, education, but that needs to sort of increase significantly. Talking about ambulances also, the thing you need to focus on with ambulances is not just the transport, it's the care they can give. Your ETUs are junior. You all know that. Your paramedics are more senior, but your ETUs, your emergency technicians, are much are very junior and their skill base is not as high as you'd expect in most of the ambulances. So there are a whole lot of things, some of them are being done, but there's a whole lot of other things that could be done. Things like stop the bleed, so that the care of the patient when they pick them up is when it starts. You don't wait until the ambulance. Fair income treatment starts at that stage, not very minor treatment, real treatment occurs. So that's things I think are worthwhile thinking about focusing on. This is my personal view, so you can say I'm wrong, I don't care. Standardising clinical transfer protocols. So you need to get the right person as early as you can to the right hospital. Now that might be bypassing, like in a large hospital, large city, like we do in Sydney, where you bypass major trauma to specific hospitals. That's relatively easy. But it's when you've got, in a small rural place, a system to be able to transfer them to the next level, the major trauma centre, to the bigger place, and know which of the ISSs, the higher ISSs, and how they're going to get there safely. You know, you've got an ambulance system, and if they improve their abilities to transfer them, then you'll be able to do it. But then you've got a problem that, at least in Australia, we have a large tax base, so that we can do a hub and spoke model, and we can get aero retrieval with fixed wing and helicopters. Now that's going to be really awkward for you, bloody expensive, that's one thing. The other thing is that even though you've got a smaller area than we do, like 12 Sri Lankas fit in just New South Wales, but as far as I know, you really can only go by military aircraft for the moment, or the patient themselves pays. That's going to be really hard, but it's something maybe in the next 10 years that when economically improved and you get a bigger tax base, that may be possible. Okay. Next one, standardised training. I actually think you do this reasonably well, but there's room to move. You know that most of the training in trauma, but the medical and nursing, is based in Colombo. Now there's some like the 80th course of the NTMC was over at Batikaloa. So you do move out a bit, and the ATLS goes out a little bit to other places too. But there probably is chances to go to provincial hospitals, large ones like Jaffna or Gaul, and increase the amount that they do there, and then go to smaller ones with modules or low fidelity simulation. I think just train the trainer, that sort of dispersal that way might be worth thinking about. Money. You've only got that much money that goes into the health system, and you've only got that much money that's going to go into trauma. So you can't have a system where you're misappropriating or reappropriating money. Now, since the NPP has come in, their action plan, that has improved significantly. But if you've only got that money, that has to be continued to be addressed to actually address the things which you need, because some of these things are need significant money, and I think it's worth bringing it up, even if I offend half of you in the audience. Now, I might offend now the other half of the audience if I could. So I'll offend this part of the audience here by saying, as was mentioned earlier this morning, that I love the doctors that come to southwestern Sydney. They have completely changed the care and the quality of care there over the last 20 years almost. But if I was Sri Lankan, I would sit there and go, I wish my best and brightest would elect to return, not be forced to return, but elect to return because they want to be back on the island, because it's so irresistibly good. If you can do that, then you'll get your doctors that you need to be able to push forward with the changes that are required in trauma, but of course it's also in critical care. So, I do love them, and I do apologise for each and every one of them if I sound offensive, but I'm getting older and offence comes easily. Pretty much at the end of it now. We've got one more thing, just to offend a few more people, is the private trauma systems. You have a fledgling private trauma system, the Lanka system, those sort of things. It's not going to be the answer. And it's fine. I work in a private emergency department, so I know. So it works for a small percentage of the population. But in terms of a trauma system, it's not really an important part of it, because overwhelmingly, people can't afford it. They just can't afford it. So it's not going to be that important. I told you this is going to be a quick talk, on purpose. See, if nothing else, I actually will keep to time, because I think that in summary, you should pick the low-hanging fruit. I think that you gain from having a island-wide trauma registry. I think that you need to develop constructional, well-organised M&M meetings so that you can get your education specifically to the areas locally that you know you're weak at. I reckon that you should try and develop universal transfer guidelines and then try and bring them in. You know, put it high. Think you're going to be able to do that. Get your hospital, your ambulance drivers skilled up enough to be able to do the transport. Have agreements from smaller to larger hospitals saying, yes, this person has an ISS of 18. They can't stay in this hospital. They need to go, and this is the system that will get there. I think bringing out low fidelity training more and more outside the major ones. Still keep the clump, don't get me wrong, keep this here as a central hub. But the more that you're able to bring it on site with the people in the place they're working, the more it will stick with more of the nurses and doctors that are working together. Sound like I think I'm God, don't I? And finally, try, if you can, to keep your best and brightest in Sri Lanka, make it attractive so that it's so irresistible to come back and work in New Zealand. If you do this, then you'll have the pieces that are required to develop the trauma system on this beautiful island that you do deserve. Thank you.
Thank you, Dr. Allen, for a nice speech. And our next topic is the airway and ventilation in major trauma beyond the RSI. The topic will be delivered by Dr. Chetna Kohli. Dr. Chetna Kohli is a UK and Australia New Zealand trained emergency physician and a sexual assault examiner, currently living and working in Prince of Sydney, Australia. She has completed a MSc in International Health and Tropical Medicine and is a keen advocate of equity and resource stewardship in healthcare. She is an instructor on ATLS and EMST course and has enjoyed various clinical lectures. Over to you, Dr. Chetna.
Thanks so much, Unika. And thank you so much to the organising committee for putting on such a fantastic event. It's really a privilege to be here. I'm really humbled and just really enjoying it. Thank you. So I was asked to talk about airway and ventilation in major trauma, thinking about the situations where RSI may not be appropriate. So RSI we are all hopefully familiar with, sort of allocate an airway team, we get some equipment out, ideally using a checklist and we make sure we don't forget anything. Give some drugs after pre-oxygenating the patient for a minimum of 3 minutes, and those drugs you probably should give it a lower dose because, you know, blood pressure. And then get the tube in the right hole. That's all there is to it. It's straightforward, isn't it? What though when it isn't the most appropriate strategy? Thinking about the airway in major trauma, even in a stable trauma patient, it's already pretty complicated. The patient's usually a Joe Bloggs, they may be unknown, they may have no ID at all. They usually have got an altered mental status either because of the head injury or maybe just the distress of having been through some horrific crash, or maybe they're intoxicated, or maybe they're just a bad person. There's the annoyance of the C-spine immobilization, which of course is necessary, but really does restrict our limit our movements. And of course, they've always had something to eat just before the car has hit the kangaroo. So even the stable trauma patient's pretty challenging, never mind the hemodynamic instability, the anatomic difficulties, the haphazard trauma team thrown together at the last minute who maybe have never worked together, and then the inherent chaos of the spaces that we all work in. So I want to thank Dr. Krupa-Mehta for sharing this awesome YouTube video, and to sort of get you thinking about the complexity that we deal with when we're thinking about airway in major trauma. I take you to Outback Australia on a quiet Saturday morning. You're driving down the road and this happens. Sadly, it's not that uncommon. Oh. So our patient is Mr. A. Let's call him Dean, or Dino by his mates. He's a 32-year-old male. He's alert. He's a bit shouty. He's probably drunk. He's got some bruising on the left chest wall. There's crepitus to feel. His abdomen is soft. Maybe it's tender, but maybe he's swearing at you just because he doesn't like you. He's already mobilized at the scene, and now he's trying to climb off the trauma bed. He's a bit hypoxic. He's a little bit shocked. He's not looking great. A diligent registrar picks up the ultrasound probe and finds some free fluid and the left lower lung floating around, and maybe there's some fluid in the abdomen as well. So what here are the immediate life threats? I mean, he's telling you quite loudly there isn't really an A problem, is there? But how are you going to get scene control to actually address the significant B and C problems that this man has got? Delayed sequence intubation is a great strategy for exactly this situation. It was first described by Scott Weingart back in 2011 as procedural sedation for the procedure of pre-oxygenation. Let's add to that volume resuscitation, getting the right equipment and the drugs and the right people to the bed space. Essentially, DSI buys you time. Scott Weingart's 2015 paper was a pretty small prospective observational study, gave us an idea that this was a feasible and safe strategy to deal with a sick trauma patient. But up until 2023, we didn't really have any RCT data. Thanks to some colleagues in India, they looked at 200 trauma patients, all of whom, of course, were young, fit men, and randomly allocated them 100 to DSI strategy, where they used aliquots of ketamine up to a dissociative dose of 1.5 milligrams per kilogram before pre-oxygenating, and then paralysis and passing the tube. The RSI wing had the same doses of drugs, ketamine and suxamethonium, but standard pre-oxygenation, RSI drugs, inductions, paralysis, and then a tube. The results were overwhelmingly positive in favor of DSI. The rates of peri-intubation hypoxia was something like 33 or 35% versus 8% in the DSI group. There were far lower rates of adverse events in the DSI group, and there was absolutely no adverse outcomes for any of the patients. There are lots of biases in this study, and I encourage you to read it to learn how to do a study better more than anything. In particular, they retrospectively actually excluded any patients that were considered to have difficult airways in an unanticipated fashion. And that was 12 in the DSI wing versus 24 in the RSI wing. And there were some other biases in terms of who they selected. It was only 200 patients out of the 1,000-odd patients they had to actually come through the doors. Regardless, the signal from a study like this, especially coming from an equivalent health system to what you have in Sri Lanka, is really positive and tells us that this is safe and it is useful. So let's move back to our scenario, and we've got patient A, Dean, who's not just this time got his hemopneumothorax, maybe he's also got a brain injury. He's come in with respiratory distress, shock, but his GCS 8 this time. He won't open his eyes, he's moaning incoherently, and sometimes he pulls away when you give him a really decent trap squeeze. So how do our priorities change in this situation? And what new potential complications do we need to prepare for? So here we've got to really think about neuroprotective intubation. We know that hypoxia a high CO2, agitation are all pretty bad for the brain. So there is a real need to crack on and get a tube in the right hole for this guy. But at the same time, RSI risks worsening hypertension, and that is very bad for the brain. Positive pressure ventilation may risk obstructive shock from his hemopneumothorax, as well as causing high intracranial pressure. And again, that's pretty bad for the brain. So basic airway maneuvers and, I was going to say, to labour the point actually, managing A before B before C as per the old ATLS mantra, it's pretty likely to result in even worse outcomes for Dean. Basic airway maneuvers and DSI may be entirely appropriate therefore. A simple jaw thrust, bag valve mask, while you do a DSI strategy, very effective. However, of course, if he is crashing with progressive hypoxia despite this, be absolutely prepared for an emergent RSI with inopressor support. Have that diluted adrenaline, aramine, noradrenaline, whatever you choose to use in your pocket. So I think of the 10 tenets of neuroprotective intubation. The first, I guess, is creating conditions for the best possible chance of first pass success. So this is not a patient that your intern should be practicing on. Ensure adequate pre-oxygenation as well as apneic oxygenation, which obviously requires a good jaw thrust and a tight seal on the mask. We now know that hyperventilating a patient to target a lower CO2 than normal range is absolutely contraindicated because it will reduce cerebral perfusion. So targeting an end-tidal CO2 that correlates to an arterial CO2 in the low normal range is probably a good idea. At the same time, as we always worry about hypotension in trauma patients, well, actually controlling or preparing for hypertension is pretty important. And sympatholysis can play a really key part in reducing that ICP spike. So while the anaesthetists are really comfortable to give people 200 to 300 micrograms of fentanyl as a push dose 3 minutes before a tube, I feel a bit uncertain about doing that for my trauma patient. And maybe just 50 micrograms of fentanyl alongside a really decent spray, some topical local anesthetic in the throat can do the same sort of job. More importantly than controlling hypertension, studies have shown us though is actually avoiding hypotension. Hypotension is disastrous in an injured brain. This means making sure we have really paying attention to how much sedation we need to give and avoiding high doses. And again, having that inopressor ready to use in our pocket. Fussing about ideal BP targets in trauma isn't really a feasible thing, as I guess most of us can appreciate, because we will often have that competing priority of hemorrhagic shock. But recognizing at the same time that true permissive hypertension is also not a great idea. It's really complicated and there's no one right answer. Some studies would suggest that rocuronium is probably preferable to succinylthonium, and while I appreciate that might not be available in Sri Lanka, the possibilities of reducing fasciculations and therefore cerebral metabolic demand is pretty good. You can have hypertonic saline, just in case you worry about raised ICP. And then all the sort of good post-intubation cares of having the head in a neutral position, reverse Trendelenburg, taking the collar off early, minimizing PEEP just to make sure they're avoiding hypoxia, and everything in the normal range post-intubation. Back to Dean. So this time round, Dean's got a hemopneumothorax, blood in the belly, he's got a bad brain injury, and trigger warning, it's a bit of an ugly photo coming up. His face has fallen off. A now is absolutely an emergent problem. He's got a soiled airway and it's absolutely at risk of disappearing in front of your eyes. As you can imagine with this, it's going to be a nightmare to pre-oxygenate, and so you really can only do the best that you possibly can. These are the scenarios that require additional help, and phoning a friend is really important as early as you can. We talk about the double setup. So this, if you're in a small place where you may be the single provider, means having a front of neck access kit or a KYCO kit open and ready to use, as well as ensuring that your whole team is fully aware that if you fail to intubate this patient through the mouth, that you're going to go for the front of neck. Ideally, a second person was going to be brave and experienced in this, is going to be ready with scalpel in hand, while your most experienced intubator is at the top end of the bed. And of course, you're going to need double suction, not just for the front of necks, but 2 at the top. We practiced a little bit of the salad yesterday at the trauma workshop, and that's not just something nice to eat. Salad is suction-assisted laryngoscopy, so you're leading your intubation with suction to clear secretions, vomit, blood, whatever's making a mess of the airway. And then having extra suction catheters ready to go, and maybe even a cut-off endotracheal tube as one of your suction catheters. So my final thoughts for these really complicated situations. Firstly, a piece of plastic in itself is not inherently life-saving, except for a very few situations, of course. So penetrating neck trauma, airway burns, where an airway emergency is apparent, that piece of plastic is not going to do the trick, and actually you may make the patient worse or kill them. Optimizing oxygenation and hemodynamics before intubation is really important. These are really dynamic situations, and urgent may turn into emergent, and so be mentally prepared for plan B, C, and D, and share that with your whole team so that everybody is prepared and expects what you're going to do next. And finally, it's all well and good saying this from a different country in a different context. Everything's going to be dependent on your own local context. And there is definitely no right answer. These are all shades of grey. And so for every difficult case you have, debrief with your team so you can learn from what's just happened and improve for the next time. Thank you so much.
Thank you very much. Thank you. Twice in 2 hours, goodness, poor thing. So anyway, you've got me for the next 15 minutes, and I'm going to be talking about halo procedures, which I'm sure you're familiar with, high acuity, low occurrence procedures, which is also a very long name for scary moments in your lives. And how to potentially avoid them. I'm very lucky in Leeds. We have a fantastic simulation lead, Catherine Holmes, give her a shout out, and she really drives our department's simulation and ability to really reinforce some of these vital halo procedures. So my aim really is to just review some of the overall structure for you, a little bit about what we're doing in Leeds to try and address this very difficult problem, and hopefully, again, to give you a few things that will resonate for you, and both in terms of challenges as well as being able to perhaps take away to your own departments to influence change. So we'll start off. This happened a few years ago. Red phone, 18-year-old male, single precordial stab wound, central carotid pulse just palpable, 5 minutes out. The problem with this was that it took the nurse 3 minutes to find me, to tell me that there were 5 minutes to go. So there was only 2 minutes. So of course, those moments are filled in the first few seconds with a little bit of coronary spasm. Do you find that at all? Maybe that's my age. But it's the key thing there. What do you do? How do you organize? What do you say to your team? The team might only be one other person, maybe 2. And how do you get ready to do the very best for an 18-year-old patient? Okay. And it's good to sort of, put up pictures that are gory and say, yeah, this is what we did. But actually, if you're in the moment at the height of it, that will go either well for you if you've prepared and if you've identified the right people beforehand, or it will spiral. And I suppose the next 10, 12 minutes are all about trying to get across to you that there are a number of these that we recognize, all of us, as halo procedures, and there are some common principles about how you prepare yourselves during your clinical lives to be able to say, yeah, I'm confident I'm going to do the really very best for this patient who comes in front of me. And the emergency room thoracostomy, of course, scenario is one example, but there are others. We sort of touched upon front of neck access already, the resuscitative hysterotomy. I don't know if any of you have ever been involved in that. Lateral canthotomies, there's a whole list. And the problem, of course, is the exposure. So, I don't know, hands up. How many people have done an RSI in this room? Yeah, so put a tube down. So that's fine. How many people have done a front of neck access? Okay, there's a handful. So I've done one in 39 years and 11 months. So that's. Or should I roll that up? Oh, okay, thank you. So if you think about it, you will, and you're honest again with yourselves, your procedural skill set will decay unless you're up at a certain level over 6 to 12 months. You might, in a emergency room thoracostomy, maybe in UK practice anyway, I know my South African friends who are here probably do between 1 and 5 a night. Most of us do 1 to 5 in a career. I've been involved in 7, I think. 1 survived. So how do you prepare? What do you do? That's the big challenge. And it's important for the patient, we know, we've talked about that. It's in the curriculum, so obviously it's very important. Certainly in the UK, there are some medical legal consequences. You might have done your best, but people are beginning to ask about what training you've had, etc. So it's important. It's also important for the team, and those of you, I'm sure, who are involved in some of these will know that the impact it has on the team, and sometimes when things go really badly, the sort of moral injury of kit not being available, the right person didn't turn up, things got tense, the patient died, they might have only been 15 because they were stabbed, sadly very common in the UK nowadays. So getting it right is so important, but actually it's not so much about the individual, it's about the team and getting a shared mental model, identifying that now is the time to do it. I think that's certainly, when I look back at times where I've made mistakes, is where I delayed in doing something when I reflected on that. So I think identifying early in your, and of course as you get more experience, you know when to make that decision. And then finding ways to do in situ drills to be able to train the system, train your people, train the kit, get the environment, make sure the calls are made in the right fashion. That's what it's really about, and it's not so much about the actual procedure, but we will talk about that. So you're all familiar, I think Maslow's model was mentioned earlier. And in terms of doing really learning a halo skill, it's about a blended learning approach and having the right sort of mix of cognitive knowledge at the base, having safety to know that actually when you are doing these skills, getting it wrong is fine. That's why you're doing it, and the ability to fail in drill procedures. And doing it as a team is vital, belonging, sharing mental models, and then getting to mastery so that you can move from unconscious incompetence through to an appropriate competence. I've talked about decay, and so there are all these skills, but there's probably a core set of things that you will not get exposed to unless you as a team do it together on a regular basis. And what's interesting, and certainly what we found in Leeds, is it doesn't matter so much about the individual skill, it's the mechanics and the human factors of doing a variety of different skills and the commonality which builds the strength in your ability and your confidence to do the right thing at the right time. So the blended learning strategy is about priming the system. You can look at videos, you can do a cognitive walkthrough, get that mental model, look at the kit. You can then go on to do that individual psychomotor core skill on sort of low fidelity models. You can then try and build that into the team. You can then do an in situ drill, which of course is very important, and you then find a way to make sure it's refreshed. And that's got to be driven by you and your portfolio. It's not about, oh, is this right? Did I manage to get through my annual appraisal because I got the right signature to be able to get through to next year? It's about really acquiring that competence and knowledge to say, I feel able to move on and maintain that skill set. So this perhaps isn't applicable as much to low resource settings. Maybe it will be in the future. Certainly in Leeds, we're trying to build up a small library of some VR modules with a local company. Allows me to show off to my youngest child at home and convince him that I'm really cool, which he's not convinced of anyway, so that's fine. But between us as a group in Leeds, we've come up with some models that allow us to practice in a VR environment. But of course, that really doesn't help on an individual basis. What it does is it acts as a bit of the cognitive skill set rather than the approach overall, which is important. So if you're in a low resource setting, there are no fancy simulation centers or high fidelity mannequins, but there is faculty and there's loads of opportunity if you can really protect your time. The high-end consumables might be expensive, so you need to find ways to get appropriate low fidelity models, and you need to make sure that you can structure that into the process. Things that work, you can have obviously various animal models or chicken bones, etc. Running small skill sessions for components and then building it together through the team is the vital key. And this is quite an important point. I think I hinted at this earlier about the role of human factors in the whole process and using these various cognitive aids. People quite like lists, obviously WHO checklists, as well as some of the airway lists that are now available. We try and do it in Leeds. I'm not sure that we're consistent on that, but I think it gives the team a little bit of confidence, and that's important. And then, of course, the environment and doing it in the right place to pick up those moments where the kit isn't where it is supposed to be, which allows the system to redress. So identify in your program all the skills that you think are really important that your residents and yourselves as consultants don't get exposure to, and set it up in a structured fashion rather than just saying, well, we'll run it again next year perhaps and see how we go. Won't go through that. So then that allows you to build an evidence base for your team, for yourself, allows you to develop the faculty and close that governance loop around doing audits and doing real skills training. So some of the pearls and pitfalls, those I'm sure are really obvious. Doing it little and often is important. It becomes the routine. So in Leeds, it occurs once a week on a Thursday morning, irrespective of how busy the department is. And we train with the kit. There's trust amongst those that get picked on. They don't know that they're about to be picked on, but everybody trusts each other. And we try and follow it up with various other cognitive aids. Time's moving on, so I'm just going to move on to my last key take-home messages. So Halo skills are vital because they define those moments in emergency medicine for us of why we exist. But we have to do it in the right fashion to minimize the likelihood of skill decay, to doing it repeatedly at regular intervals. Not that individual skill necessarily, as I said, it's that global appreciation of the structure and the team which builds the trust and the confidence and then acquires the mastery. Blend it with the various aspects and appreciate psychological safety and the importance of your team. Thank you very much.
Thank you, Dr. Taj Hassan, for that wonderful talk. As always, really nice to listen to you. Next, I have happy to introduce my good colleague, Dr. Dilki Padmadasa, consultant emergency physician from the Accident Service in National Hospital, Sri Lanka. Dr. Dilki graduated from University of Jayawardenepura in 2015, and she has obtained an MD in emergency medicine in 2022. She works as a consultant in Accident Service in National Hospital, Sri Lanka, where she provides expert care for patients with a wide range of surgical and traumatic emergencies, one of the country's busiest trauma tertiary care centers. Her clinical interests include trauma, resuscitation, critical decision making, and delivery of high quality emergency care in resource-intensive, high acuity environments. She is actively involved in leading multidisciplinary teams and managing some of the most critically ill and injured patients in this country. Today she will be speaking on endpoints of trauma resuscitation. When are we winning? Go ahead.
Thank you, Dr. Prasanna, for the detailed introduction. Good afternoon, dear colleagues. So when I was asked to talk after lunch, I thought like the whole audience will be asleep. But quite interestingly, everyone is like up and alert. Guess why? Because major trauma is always an adrenaline rush, isn't it? Whenever, as emergency physicians, when we get this AD major trauma call, we know the adrenaline rush. So I think that's the reason why you all are up and alert. So we had quite interesting lectures today regarding trauma, like airway challenges and important life-saving skills, how to be updated, and what can we learn from high-income countries to update our trauma systems. What are we trying to do by this stuff? We are trying to win. We are trying to win that patient who comes with major trauma. We are trying to win that life. But how do we know whether we are winning or not? Because sometimes when this major trauma patient comes to your resus bay, most of the time, you know, like depending on the patient's situations after resuscitation, whether the patient is winning. If they win, we win. But sometimes, unfortunately, if there are any unsalvageable injuries, we might lose. But there is always this one patient we thought like, okay, we were winning, but we lost that patient, isn't it? Maybe during our training years. So we all had that experience. So I'm going to talk about resuscitation endpoints in trauma. When are we winning? So in my lecture, we will be discussing about resuscitation endpoints, recognize the limitations of the traditional endpoints which we have been using, and the importance of biochemical and perfusion markers, and discuss the challenges we face in limited resource settings in countries like us. So we'll start with a patient. We have a 28-year-old male patient coming following a motor vehicle collision. Blood pressure is 110/70, heart rate is 92, swelling in right thigh, no open wounds. We all had this patient, isn't it? Looks all right, numbers are good, the heart rate is slightly high, but he got a right thigh swelling, maybe a femur fracture. Looks all right to me at the moment. Are we winning? What do you think? Okay, so this is how the blood looks. The lactate is 4.8 and base deficit is -6. I don't think we are winning at this stage. So whenever we discuss about a resuscitation of trauma patients, the first thing is, you know, our primary survey X, A, B, C, D, E. X is for exsanguinating bleeding. So if there is a patient who is bleeding actively, stop the bleed. That is the first step of endpoint of resuscitation, because no point of filling a tank if there are holes. So always look into whether there are any exsanguinating bleeds or there can be internal bleeds. So always look for the bleed. And even though the blood pressures and the heart rate looks all right, why that patient had abnormal blood parameters? That's the story which happens beyond vitals. So if you see these bleeding patients, they will be having tissue hypoperfusion. With all the compensatory mechanisms, the blood will be shifted to protect to protect the heart and the brain, where the blood supply is cut off into skeletal muscles and gut. So there is ongoing anaerobic metabolism and lactate production. And there is an oxygen debt and a cellular dysfunction leading to organ failure. So when we are resuscitating a trauma patient, our aim should be to restore the adequate tissue oxygen delivery. Just because the heart rate or the blood pressure is normal doesn't mean that the oxygen delivery is normal. There is always an oxygen debt in a trauma patient who lands in your trauma bay. So always look into that oxygen debt, whether your patient has it or not. So these are the traditional endpoints we are familiar with: the heart rate, blood pressure, MAP, and urine output. So the biggest advantage is we are quite familiar and it's easy to measure, isn't it? Even a layperson can get these values if they are trained. But the limitation is it doesn't reflect the tissue hypoxia. That is the main thing. It will reflect how good his compensatory mechanisms are. But beyond the vitals, there is always a story going behind. So then comes lactate and the base deficit into play. So why lactate? When there is tissue hypoxia, there is anaerobic metabolism producing lactic acid. So this byproduct we can measure with our very simple bedside blood gas analysis. So if the lactates levels are high, it indicates there is tissue hypoxia. The oxygen delivery is not adequate. So the EAST guideline, Eastern Association for the Surgery of Trauma, it has mentioned that there are studies found the time needed to normalize serum lactate level was an important prognostic factor for survival. In this study, the time taken to normalize lactate level less than 24 hours, almost all of those patients survived. But if the time taken was 24 to 48 hours, there was a mortality of 25% rate. And if it took more than 48 hours, the mortality rate was quite high, like 86%. So that itself indicates how important lactate is. And it's not just a single value. It should be a serial measurement because the lactate clearance is associated with improved outcomes. Base deficit. So it's a marker of base metabolic acidosis. Whenever there is lactic acidosis, your H plus is buffered by the bicarb in your blood. So when the buffering mechanism, the compensatory mechanisms are active, it will be reflected in your blood gas analysis as a base deficit. So the severity is, it relates to the number. So if it is -2 to -6, it's mild, and -6 to 10 is moderate, and more than, like less than -10 is severe shock. So it's an indicator of shock, and it indicates the cellular level hypoxia. And of course, the first base deficit value is a predictor of transfusion requirement. And its guideline also says that the initial base deficit is a mortality indicator as well. So make sure you look into numbers beyond vitals. So if you compare lactate versus base deficit, so both are markers of cellular hypoxia and anaerobic metabolism. But certain other factors can mask these levels. Like if you take lactate, if the patient is already a liver disease patient, they will have higher lactate levels. And if you take patients who had previously mixed acid-base disorders like a COPD patients, they may be having a baseline of high bicarb. So in that case, never go by single value of a lactate or base deficit because it complements each other. So take it together and decide your resuscitation. Yes, and we know in our modern trauma practice, resuscitation practice, there is a lethal diamond which includes the coagulopathy. So make sure you correct coagulopathy. When a patient loses blood, it's not just hemoglobin they are losing. They are losing clotting factors, they are losing platelet. So always don't forget to get your coagulation studies. So it depends on the sector where you work. If you are in a level 1 trauma center, you can do a TEG thromboelastogram. But if you don't have, you can go with your good enough lab investigations like INR, platelets. Temperature and calcium, those two are also included in lethal diamond. We call it the forgotten endpoints. So your trauma patient is always hypothermic because of the environment, and he has lost a lot of blood. So with that, they lose their body temperature. So always make sure the patients are warm and replace their calcium because the calcium is an important cofactor in coagulation pathways. So while you are resuscitating, beyond numbers, it's not just the lactate or the base deficit. You are good enough, all clinical examination matters. So look for the patient's capillary refill, peripheral temperature, mental status. If the patient's mental status is improving with our resuscitation, we are happy, aren't we? So it's always important to reassess. The dynamic response to our intervention gives us a good clue whether we are winning or not. So patient in your trauma bay, if his lactate is rising, temperature is falling, worsening base deficit, continuous bleeding, persistent hypertension, we know that we are not winning. There is something going wrong in his physiology, and we have to look what's wrong, what did we miss. But if the lactate levels are falling, it's getting corrected, base deficit improving, patient is producing good urine output, bleeding control, coagulopathy corrected, warm patient, hypocalcemia corrected, I think we are winning, both patient and us. Yes, this comes the challenging part, especially in low resource countries like us. I would say limited resources rather than low resources, because our resources are not evenly distributed. So if the challenges are, if you are in a limited resource hospital in a trauma bay, so you won't be having all these investigations. There will be lack of staff, the investigations will be delayed, and even sometimes you won't be having definitive surgery facilities. So in that case, does these endpoints apply? What are the endpoints like? How are we going to stabilize? Maybe we are running out of blood. It's just only 2 units of blood available in this peripheral hospital blood bank. So what is the endpoint? So then in that case, we have to be practical. Of course, emergency physicians, we are always practical compared to other specialties. So try to achieve effective hemorrhage control. Try to restore some amount from that patient's vitals. I won't say you will be able to achieve good blood pressure, but start transfusion and prepare him for urgent transfer. So if you are in a limited resource facility, you should know when to transfer. That is one of your endpoints, because there is a limit where you can resuscitate, and if you want to win, you have to give the baton to the other team. So make sure you decide on early transfers. So as I am working in a level 1 trauma center, sometimes we see patients who land with delayed transfer and will have poor outcomes. So that is very important, when to know transfer. That is also an endpoint. So the endpoint of resuscitation is not always definitive care, because if you don't have blood, if you don't have theatre, if there is no surgeon, you cannot provide definitive care. So timely recognition of limitations and safe transfer to a trauma center is very important in a country like us. So take home messages, there is no single endpoint predicts adequate resuscitation. So just like trauma management is a teamwork, patient's physiology assessment is also a teamwork. It comes with clinical assessment, physiological variable, biochemical markers assessment, imaging, and know what resources you got in your hand. So to conclude my talk, I would say normalizing blood pressure or heart rate doesn't mean you are winning. Normalize patient's physiology, then you are winning. Thank you.
Thank you, Dilki, and thanks to all the speakers for keeping to time. Lots of good wisdom and experience, which I appreciate in so much aspects of trauma. We are a bit late, but we still got time for a couple of questions, and I would encourage the audience to ask any questions if you have now. All right. I thought I saw someone standing up, but that's fine. All right. For the interest of time, I would like to thank all of our speakers coming all the way here, spending their time and effort to teach us all these important things. And that will bring us to the end of the trauma section of our conference. Thank you.
I would like to thank our speakers for their enlightening presentations. And I would like to thank our chair and co-chair for that engaging session. To honor the valuable contributions of our speakers, I would like to invite Consultant Emergency Physician Dr. Inuka Vijay to present the tokens of appreciation to our speakers, Dr. Alan Giles and Dr. Chetna Kohli. Thank you, sir. Now, I Consultant Emergency Physician, Dr. Nadraja Prasanna, to present the tokens of appreciation to Dr. Taj Hassan and Dr. Dilki Padmadas. Thank you, sir. Once again, please join me in giving a round of applause to our speakers for the lovely presentations.
Ladies and gentlemen, we now move into plenary 3, which focuses on the IFEM Emergency Department Quality Framework. Delivering high-quality emergency care goes beyond clinical excellence. It requires robust systems, continuous measurement, and a culture of quality improvement. The IFEM Emergency Department Quality Framework provides a globally recognized roadmap for emergency departments to evaluate performance, improve patient care, and deliver consistently high standards of care. It is now my great pleasure to introduce our speaker, Dr. Sarvana Kumar, to deliver this plenary address. Dr. Sarvana Kumar is a consultant emergency physician and a group unit head at Dr. Mehta's Multidisciplinary Hospitals, Chennai. He is the chair of the Quality and Patient Safety Special Interest Group of the International Federation for Emergency Medicine. Ladies and gentlemen, please join me in giving him a warm welcome.
Thank you. 3 questions. Quick raise of hands. How many of us here genuinely want to save a life of a patient? Great. Second question, how many of us here doesn't want to kill a patient? Okay, I'm going to ask my third question. But take about 10 seconds to answer this internally. How many of us have actually killed a patient? If your answer was yes to any of these 3 questions, I think this talk is for you. I think this event started at 8 a.m. today morning. Yeah, we are at around 3 p.m. roughly, so it's roughly 7 hours. About 231. If you're wondering what is this 231, that's the number of patients in our emergency departments across the globe who lost their lives. Not because of trauma, not because of cardiac illness, or not because of what they came into an emergency department. That's because an emergency physician like you and me, who genuinely wanted to save that life, who doesn't want to kill that patient, unfortunately ended up doing the same because of an error, because he didn't focus on something. I think this was the question which was pondering many of us in the quality SAG at IFEM, and we're thinking, how do we now solve this unspoken issue in all our emergency departments? If a patient arrives in Colombo or Mumbai or Dublin, should the quality of care they receive depend on which city they land in? Do you think it should change across the globe on wherever they are landing in? I don't think it should. So that's where 19 experts from IFEM gathered together. We worked across for closer to 12 months to bring together a standard set of global emergency medicine standards, which recently got launched at an IFEM global event in Hamburg. And there is also a pathway for certification if you wish to get your department certified through that pathway. But my talk today is not going to be on the standards itself. Mine is going to be slightly different. I wanted to give you all quick takeaway lessons from this to your emergency department. Start your shifts
in whichever department you are or whichever level you are in, let's make the emergency departments a little bit safer than where it is today. Based on our collective discussions over the last 12 months and reference to various existing quality standards across the globe, we were able to see there are 10 critical areas in emergency department which we need to focus on to ensure our patients are safer and there is genuinely quality emergency care delivered. You can see I have marked 3 in a different color: the leadership, safety as a system, and staffing. That's the key focus of my talk today. And apart from that, clearly there is infrastructure, process, documentation for continuity of care. How do you engage families as a part of continuity of care? How do you learn from your mistakes, near misses? And why we need to continue this journey of quality and it doesn't stop? And how do you measure the right metrics for your emergency departments? Of course, I'm not going to cover everything. I'm going to give you key points for you to understand which are those areas we can focus on. Very common scenario in most of our emergency departments. Got a patient at 3 a.m. in the morning. The ECG is not very steady. You want a second opinion. You ask 2 of your seniors or a senior consultant, and both of you give very different opinion and a pathway to treat. Now, which one do you go ahead with? Would you listen to consultant 1 or consultant 2? Or assuming 2 cardiologists give you 2 different opinions, which one should you follow? I think that's where actually leadership matters. Many of our departments don't have a clear escalation pathway on what happens next if you are stuck. That's not just in any clinical scenario, but it could be applicable in any other scenario as well. Especially when you don't have a senior expertise around. That's what we need to be building on, and that's what leadership is all about. Few tips around what we can do: daily operational huddle, named escalation pathway. How many of us here have got a very clear escalation pathway? If you got a issue in the department, whom do you raise to, and then if that person is not reachable, how do you go to the next level? How many of us have it? Very few hands go up. Leaders rounds the department, basically not just around, you need to be physically present as a leader, and every serious incident is followed by a team learning session, and say actually designed and not assembled. We hope we bring in a good expertise of doctors, put them together in a room, name it as an emergency department, and stick to few clinical protocols, and we assume things are going to go right. That's not how systems work. Safety is a system and not a department. Look at it as a system error. Today morning, when I was rushing to catch my flight to Colombo from Chennai, I was late to the airport. And before boarding, I need to use the restroom, and unfortunately the boarding has started. In that hurry, I went to the restroom and I forgot to latch my restroom door. And somebody accidentally opened it. Very embarrassing moment for me. Whose fault is it? Whose fault is it? I was thinking it's my fault. And then I boarded the plane here. And I happened to use the restroom in the Sri Lankan Airways flight. And there it struck me, it was not my fault. You know what? I realized the lights in the restroom only comes on only if you latch the door in the aircraft. What a brilliant system designed to prevent this embarrassing error, right? So don't blame yourself for all the errors. It's not person's fault, it's always a system's fault. So it's always an opportunity for you to build systems, right? So this is how you need to think when you see an error in the departments, right? Very common scenario, medicine prescribed. Most of us know this as a Swiss cheese model, where there is multiple opportunities for us to correct an error, especially with a medication error. And most often what we find in our departments is the nurse at the point of administration has identified that this is not the drug or dose to be given, right? That's probably the last stage. If your department does it, that actually means your system has already failed. If nurse is your last resort of safety in preventing medication error, that actually means your system has already failed. Think about it. You got to build strong systems in preventing medication errors, mandatory secondary checks, visual double identification, and many different methods, barcoding method. I'm not going into what you can use, but think about something on how do you prevent this medication error. It's very common. How many of us here has overdosed a child in an acute emergency situation? Because we didn't use a simple dose calculator. Very common in most of our EDs. The third common problem is utilize them. Many of us make this mistake of quantity of staffs, nurses and support teams required. But we don't actually look into their competencies to see, have you got competent people spread across different shifts? Many a times we think the emergency department is busy, there's a lot of onboarders, but how many of us have actually mapped what is the time period or the peak period where you got this problem, and how do you now readjust your staffing level so that you got a good cover of staffing and competent staffs across your most critical period of emergency departments in those 24-hour shifts. These are some of those areas where we can focus on to bring in system improvements for preventing critical errors. Infrastructure and processes play a significant role. If you don't have a good emergency medicine design, errors are going to happen. There are about 200 emergency physicians in this room. If I bring in a trauma patient here and all of us have to still work on him, I'm pretty sure this patient has got very little likelihood of survival, because this room is not designed to handle such an emergency in spite of having the best expertise in the world sitting here. That's a reality of infrastructure. Focus on how do you build a good infrastructure which is suitable for. At the end of this, I'm going to give you those standards which you can download using a QR code for what you can do or how you can bring about those good designs. Processes, of course, it's very, very important. Clinical processes and administrative processes. Many of our departments, we are quite happy to perhaps paste big algorithms of ACLS, PALS, neonatal resuscitations, RSI, right? So clinical algorithms, how to manage snake bite, how to manage poison. Don't do escalation. Documentation, other blind office. And I think with the advent of electronic medical records, I'm not sure how many institutions here use electronic medical records. The gap in the communication has actually worsened by using more electronic medical records, because somehow we started to think it's my job to enter and it is somebody else's job to read through it to understand. When it was all manual, we at least had some degree of conversation going between each other, right? I think so. Be aware of that, and alarm fatigues and all of those things. But documentation is extremely important, as it's not just what happened, but it's actually continuity of care. Imagine if a patient has to return back to you after 6 or 8 hours of first emergency department visit, and none of your colleagues from the previous shift has documented what has happened, what's the plan of care. How do you go about this patient? It's going to be tough for all of us. And of course, how do you engage families as a part of care? Many times we think we know it all, but that's not the case. So many times, I come from a setup from Chennai, where 50 to 60% of our emergency patients are children. And mothers are extremely smart and they can pick up the symptoms better than we do. And also, in case of a change in medicine, they're quite smart to tell doc, this is not the color of the medicine or size of the medicine you gave to her last time. So many times they have helped save our skin in that situation. Near misses. What happens in shift 1 gets buried and hidden under the carpet and the news doesn't get out. That's not how we should be looking at near misses. We don't communicate errors to our own colleagues or teams, and we actually let them all do those mistakes and learn from them. I think that's not the best way to go about when it comes to learning from errors. You got to learn from others' mistakes. And how do we do that? We got a culture. We have to have a culture of sharing those errors, discussing about them without any, and look for system fixes. I've been talking about this word system multiple times, just to give an easy understanding of what a system basically means. It's structure plus a process is equal to a system, equal to an outcome. There is a structure, there is a process, there is an outcome. There is a good emergency department with good manpower plus a good clinical protocol gives good clinical outcomes. Structure, process, outcomes. A good example in other emergency department, for example, you want to improve hand hygiene or infections pertaining to poor hand wash. What is the first thing we all do? We gather everybody, do multiple trainings, 5 steps, 6 steps, 10 steps of hand wash, all that, right? Good training process. But what we have forgotten is, do we have adequate water facility, sink facility, or at least hand sanitizers across each of those beds for them to use? That's an example of a structure. So how much of a process improvements you do when you don't have a good structure, it's going to fail the outcome. Or if you don't have a good process but a great structure, it is still going to fail the outcome. So always think about structure. Premises is a great opportunity to see whether it's your structure which failed or the process, and how do we correct the outcomes now. And the last 2 lessons in this quality document which we have mentioned is about key performance indicators and how do you measure the quality of our department. Most likely, and I'm pretty much sure that all of us are measuring return to ED within 24 hours time, door to triage time, door to doctor time, door to balloon time, correct? And maybe mortality, or some of you are smart, adjusted mortality rate, correct? That's exactly how you don't measure KPIs for your emergency department. Why are you measuring this? Because either somebody else told you to measure, or an accreditation or a certification body told you to do that, or you Google through and that's what it gave as a standard measures for your department. These are not, but the right way of setting an KPI is for you to understand what you want to improve in your emergency department, what's failing now, right? And what you want to improve. That's the outcome you need to start measuring so that you can continue to improve on that. Not because the data is readily available or somebody else has asked you to measure something. So when you set KPIs for your department, always remember, pick on those things which you really want to improve and excel in your emergency department, not your standard set of KPIs. And of course, what gets measured will obviously get improved. So we all know that. So what's a bigger lesson? Different chapters, different standards. We had 265 standards written there in that document. It's a good 80-page document. But clearly it all boils down to probably about 4 things. Taking that leadership and ownership, understanding others' mistakes, and also showing that accountability to kill a patient. I think that's what excels ourselves as emergency medicine physicians. So 3 things to take back to your ED starting this Monday, right? What do you want or what we can do? A lot of things you can read from the document, but you can't obviously implement everything. So what you can start? Build leadership infrastructures, right? Start a daily 5-minute huddle. Start this week. Put an escalation pathway if you don't have one. And assign a visible nurse and a clinician leader for each of your shifts. Second, design a safety system. Don't leave it to chance. Map one patient harm. Look at one patient harm which has happened in your department over the last 3 months. Study that in deep to see what sort of a system and process fixes you need to make. Make sure you have a secondary check, especially around your critical medications, high-risk medications, narcotics. And please also communicate to your patients. It can be even a simple signboard to say, if you look something odd, or if you feel something is odd, please do speak up and tell us. And the third thing is clearly measure 3 things. Whatever KPIs works for you. I'm not suggesting go to measure these 3, whatever you want to improve. But make sure you review them weekly with accuracy. It is not just about measurement for 3 months or 6 months and giving it to the management or the ministry. It's for you to review to improve. And of course, celebrate the trend, hopefully the positive trend. I'm not meaning the negative trend, but make sure as it grows, you've got to continuously improve on that. There is no end point to quality. You cannot say my door to needle time is 30 minutes, I have achieved it, so I'm done. That's never works that way. So it has. So coming back to the earlier question, I'm sure all of us will agree that care shouldn't be different wherever the patient lands in emergency departments, right? So whichever city, whichever country it is. So that's why we got this global quality standards. And this is a quick scan for you all to download this. This is available today in the International Federation of Emergency Medicine webpage for you to read for yourself. There's a lot of information out here. lessons around this on what you can implement from this on coming Monday morning. And any of you are interested and keen on taking this forward to see how you can implement all these standards and perhaps get yourself certified, you are most welcome to do so. To date, there are about 3 gold certifications across the globe, 1 in India, 1 in Philippines, and 1 by Cleveland Clinic, Abu Dhabi, 3. So if you want the 4th one to be in Sri Lanka, you are most welcome to apply. My next slide and the last slide is for those who are just starting your journey or emergency department journey. If you are new or if you have set up a newer emergency department, and if you think this is quite comprehensive for you to implement or quite complicated for you to implement right from day one, I got another set of standards for you to look into. These are probably, you can say, basic set of standards, not from IFM, but this is a good 3 years of work the Society for Emergency Medicine India did along with Indian Space Research Organization to actually improve quality and patient safety in emergency departments. These are basic guidelines for those new emergency departments on how to set up flow, infrastructure, all those basic details. If you want to learn, implement right off the shelf, this is the guidelines for you. I think with this, I wish you all a great learning experience, and thank you organizers for inviting me over for this wonderful event. Thank you.
Thank you so much, Dr. Sarvana Kumar, for that excellent and insightful presentation. May I invite Dr. Nadaraja Prasanna to kindly come forward and present the token of appreciation to Dr. Sarvana Kumar as a gesture of our sincere gratitude. Ladies and gentlemen, please join me in giving Ladies and gentlemen, before we move on with the rest of the day, we have a small message from our organizing committee. The MRChem Oxy Speed Mentoring list. So I have the candidate list with me. I will be mentioning these names. And if your name is there, please be present by 7:30 in the morning tomorrow at the Orchid Hall. And there are few more slots available, and if you are interested, please contact our organizing committee. So the names are Dr. V.G. Marisha Fernando, Dr. Metmal Malavarachi, Dr. S. Mahendra Raja, Dr. G. Shrizana, Dr. J. Indura Miranda, Dr. M.A. Nadisha Ushani, Dr. H.T. Pasindu Prabodh, Dr. L. Madhushankar Suryarashi, Dr. K. H.R. Shakila Kumari, Dr. G.L.S. Amanda, Dr. H.M. Kayani Nirmala, Dr. M.H.A. K.P. Karnaratna, Dr. D.S.C. Veerasinghe, Dr. K.M. K.P. Kadugat, Dr. M. Ahmad N. Ali, Dr. Yoganathan Gaurin Sam, Dr. K.S. Lakshita Vijayavanta, Dr. Y.N. Rajapaksha, Dr. Nazat, Dr. M.M. Gikuruwa Gamage, Dr. K.T.B. Priyadarshani, Dr. Deheragoda, Dr. Delvatta, Dr. Tharindu Vidana Gamarachi, and Dr. Noni Kumarage. So these candidates, please be present by 7:30 tomorrow. As we move into our final scientific session for the day, we now begin Symposium 4, titled Complex Patients and Collective Decisions. The emergency department is where complexity meets urgency. The topics in this symposium highlights conditions that require swift recognition, sound clinical reasoning, and a collaborative decision making to achieve the best patient outcome. May I now invite the chairs of the symposium to kindly come forward. Dr. Viraj Rajapaksha, Consultant Emergency Physician, Colombo South Teaching Hospital. Dr. Dhanuka Senatna, Consultant Emergency Physician, Colombo South Teaching Hospital. Thank you for joining us, sir. Let me introduce our distinguished panel of speakers. Please welcome on stage Consultant Emergency Physician, Dr. Achala Buddhika Galayadda, Consultant Emergency Physician, Dr. Shamila Prashant, Consultant Emergency Physician, Dr. Nivedan Padmanathan, and Consultant Emergency Physician, Dr. R.M. Amila Dinendra. I now invite the chairs of the symposium to kindly take over the proceeding and lead the symposium. Thank you.
Thank you. Good evening, distinguished guests, ladies and gentlemen, and dear trainees. So we come to the fourth and the final symposium today. So first, I would invite our first speaker, Dr. Achala Buddhika Galayadda. He's the consultant emergency physician from Base Hospital, Nuwara. He obtained his MBBS degree from University of Peradeniya, and in 2006 he got his MSc in community medicine with a gold medal, and in 2022 he obtained his MD in emergency medicine with special interest in trauma care. Dr. Achala to discuss his topic, cardiogenic shock in emergency department.
Thank you very much for your kind introduction, and good afternoon everyone. And it's a great honor to deliver my speech on cardiogenic shock in the emergency department at this annual academic congress. So I'll begin my talk with some statistics and cardiogenic shock in the emergency department. There is 40 to 50% of in-hospital mortality due to cardiogenic shock, and the number one cause for cardiogenic shock in the emergency department is acute myocardial infarction. And despite the advancement and the development of medicine throughout the world, the mortality remained stagnant over the last 20 years. And there is a UK guided shock to survival framework with 5 steps. In next 15 minutes, I'm going to talk about early recognition, evidence-based management, mechanical cardiac support, and novel therapies of cardiogenic shock. As you all know, cardiogenic shock is sustained tissue hypoperfusion due to cardiac output which fails to meet metabolic demands of the body, which is due to cardiac dysfunction. When do we need to suspect cardiogenic shock? If a patient comes with a blood pressure less than 90 millimeters mercury, which is consisting for more than 30 minutes, or needing vasopressor support to maintain systolic blood pressure more than 90, with clinical lactate more than 2 millimoles per liter. with signs of poor motor peripheries, low urine output, and altered mentation. How can we confirm cardiogenic shock? So, ECG might meet STEMI criteria, or 2D echo will show left ventricular systolic dysfunction, severe valve abnormalities, or structural defects. Remember, some patients will not show features of hypotension, especially if they are very young and having excellent compensatory mechanisms. So, 5% of the cases will not show hypotension. So, we have to suspect cardiogenic shock. There is no single variable which is diagnostic, and cardiogenic shock can occur with preserved left ventricular function. So, this is the shock to survival framework, which has 5 key steps. First one is the early recognition with signs and lactate and the SCAI staging system. That is a staging system, Society of Cardiac Angiography and Intervention. That is an international staging system, which I'm going to talk about in next slide. And then at the second stage, we have to do early intervention, like we have to try to reverse the causes, starting fluids and inotropes, and then we have to classify the cardiogenic shock according to the SCAI classification system, and then we have to escalate the therapy or escalate the treatment with communication with the CCU or ICU to buy time, and then we have to get expert input from multidisciplinary teams, shock teams, to save our patients. This is the SCAI shock stage classification, which is one of the international communication tool to communicate regarding cardiogenic shock with one institution to other institutions, or from one clinician to the other clinician. At this stage 1, which is the at-risk stage, they do not show any features of hypotension or organ hypoperfusion, but they have high risk factors for cardiogenic shock, like large acute myocardial infarction, decompensated heart failure, like features. Their blood pressure is not perfusion. But they do not show any evidence of hypoperfusion. They are having both hypotension and hypoperfusion. They require pharmacological or mechanical support. At the deteriorating stage, they are failing to respond to initial treatment, so we have to escalate pressures. At the extremes, it is impending circulatory collapse. Few words about inotropes and vasopressors. We have to maintain the mean arterial pressure more than 65. Noradrenaline is the first line vasopressor when the patient is unresponsive to fluids and continuously having hypertension. In that case, we have to titrate noradrenaline to maintain the mean arterial pressure more than 65. And sometimes we may have to combine with dobutamine if the patient shows features of low cardiac output. And dobutamine will be the first line inotrope if the patient shows features of low cardiac output with peripheral vasoconstriction. But remember, dobutamine may cause vasodilatation, causing reduced blood pressure. In that case, we may have to add noradrenaline as well. In emergency situation, like if the patient is going to cardiac arrest, and if we do not have immediate IV access, we have to use adrenaline. And milrinone and levosimendan should be used with expert opinion. Milrinone is preferred if the patient is on beta blockers or the patient is having severe pulmonary hypertension. And levosimendan is a calcium sensitizer. It's useful if the patient is having evidence of heart failure. And if I talk about the mechanical circulatory support, we have intra-aortic balloon pump, microaxial flow pumps, and arterial ECMO. So each of these methods have their own benefits and limitations. Intraarterial balloon pumps, they are easy to insert and cost effective, and they have favorable adverse event profile, but they provide low level of hemodynamic support to the patients, and they have not shown any survival benefit in randomized controlled trials. And myoaxial flow pumps, they are providing univentricular support to the patients, and they have shown increased 180-day survival according to danger shock trial, that is Danish-German shock trial, with number needed to treat with 8. And their limitations are, they have less than 5% cardiogenic shock patients meeting criteria, and the high risk of bleeding and vascular injury are there, and they are more prone to have sepsis, and some required to escalate to VA ECMO. And benefits of VA ECMO are, they provide full biventricular and respiratory supports, and they are useful in refractory cardiogenic shock. And limitations are, according to ECLS shock trial, they have not shown any mortality benefits in routine early strategy as in acute myocardial infarction cardiogenic shock, and it is bit confused and resolved more severe. A few clinical trials before the danger shock trial, which was conducted in 2024, have shown increased 180-day survival benefit in MFP, and ECLS shock trial, which was conducted in 2023, not shown any significant difference in 30-day mortality in VA ECMO, and intraarterial balloon pump shock 2 trial, which was conducted in 2012-13, have not shown any more. Coronary angiography and revascularization. If the patient is having STEMI and patient has presented to PCI center, we have to do an intervention within 60 minutes. And if a patient is come to with a STEMI to a non-PCI center, we have to transfer this patient to a PCI center within 90 minutes. And if it is a high-risk non-STEMI, we have to do the invasive strategy within 2 hours. And if the patient to a facility PCI center within 90 minutes, we have to start thrombolysis within 30 minutes. And the shock team consists of a cardiologist or heart failure specialist, interventional cardiologist, intensivist and critical care specialist, cardiothoracic surgeon, cardiac anesthetist, and a perfusionist. When do we need to activate this multidisciplinary team, cardiogenic shock team? If the patient is having refractory cardiogenic shock with SCAI grading D to E, and if the patient needs more than 2 vasoactive agents to maintain the blood pressure, and if the patient is needing medical cardiac support, or if the patient is having uncontrolled arrhythmias, or if the patient is having heart disease, myocarditis, in that case, discussion with multidisciplinary team. This is the ED management algorithm, and we have to initially recognize and monitor the patient with 2LD ECG and cardiac monitoring, ABG, chest X-ray, and stabilize the patient with maintaining saturation more than 94, getting IV access. If there is no congestion, we should start IV fluids and iron drops. And we have to stage the patient with, according to the SCAI classification system, and if needed, we have to refer or transfer this patient. And we have some special population and transfer priorities. The priority 1 is immediate transfer and priority 2 is urgent transfer. If the patient is having life or limb-threatening conditions, and if the patient is having immediate critical care requirements, in that case we have to immediately transfer these patients. And we have to consider if the patient is having culturally and linguistic diversity, in that diversities, we have to use interpreters. But in Sri Lanka, we have only main three languages: Tamil, Sinhalese, and English. So we may not need any interpreter services. In priority 2, if there is if they do not have any immediately life-threatening conditions, and the temporary stabilization is possible, and time frame agreed between clinicians, we can transfer them urgently. And we have to cater the patients if they are having any cultural requirements. In Sri Lanka, there are not that much of cultural requirements, but in Australia, if the patient is like Aboriginal origin, we have to have a liaison officer as well. So a few words regarding monitoring, governance and education. In emergency department, we have to do some audits and training programs as well. Key performance indicators for audits are number of confirmed or suspected cardiogenic shock patients per month, and transfer to higher facilities within 6 hours of presentation, patients requiring high-dose inotrope supports like that. In our training curriculum, we should include how to identify and recognize cardiogenic shock early, and SCAI staging system, and escalation pathways, and initial stabilization strategies, and likewise. So this is the evidence at a glance. They have strong recommendations to early recognition before endocrine dysfunction occurs, and noradrenaline is the first line vasopressor if there is the low blood pressure, and dobutamine is the first line vasopressor if there is low cardiac output. And if we are doing any coronary angiography, we have to go for only single vessel. We do not touch multiple vessels at once. And the involvement of multidisciplinary team shock trial is highly recommended. Yeah, take home messages: suspect cardiogenic shock early, and SCAI staging is your common language. Noradrenaline plus dobutamine are first line agents, and danger shock proved impeller benefit in very selected ischemic cardiogenic shock, and protocolized shock teams saves lives. Thank you very much.
Thank you very much, Dr. Achala, for the insightful presentation. So our next speaker for the evening is Dr. Sharmila Prashant. She is the consultant emergency physician working in the District General Gampaha. Dr. Sharmila graduated from University of Jaffna, Faculty of Medicine in 2010. She achieved her postgrad diploma in critical care in 2015, later got her MD and became a member of Royal College in 2021-2022 respectively. Her special interests include studying on endotracheal intubation in ED. Over to you, Dr. Sharmila, to edify us on hypertensive emergency in pregnancy.
Good afternoon, everyone. Thank you for that introduction, and thank you for having me here today. My topic is on a clinical problem that has effect on two lives: mother and the baby, hypertensive emergencies in pregnancy. So today I'm going to focus on my talk on ED priorities of managing this patient. 1, recognizing early. 2, stabilizing the mother, and escalating early to the multidisciplinary team for planning the definitive care. So let me start with a case. So this is a 29-year-old woman, 34 weeks of gestation, coming with headache, blurred vision, epigastric pain. Her blood pressure is 178 by 160 millimeter mercury. Urine protein is 3+. She's awake, talking. may not look unwell at first glance, but this is already a high-risk presentation. What worries us most? What worries me is a combination of elevated blood pressure with neurological symptom and epigastric pain. She is already at risk of hemorrhagic stroke, preeclampsia, eclampsia, HELP, etc. So why this is important for emergency physician? Let's look at the burden of this disease worldwide and Sri Lanka. So worldwide, up to 1 in 10 pregnancies affected by hypertensive disorders, nearly 42 maternal deaths each year due to this problem. That accounts for nearly 16% of maternal death annually worldwide. This is WHO record. In Sri Lanka, we are lucky enough to have low maternal mortality ratio, but still it affects 1 in 10 pregnancies, and also it accounts for nearly 5% of maternal deaths each year. Roughly, Sri Lankan maternal death is around 50 to 75 per year. So in this case, what is the most important action that we have to take? Yes, blood results are important, obstetric review important, CTG important, but none of these should not delay maternal stabilization. So the ED priorities are fall in 3 main actions. The first one is recognizing the severe disease, start maternal stabilization early, and escalate early to the multidisciplinary team for planning the definitive care, that is the delivery. Pathophysiology. Let's look at briefly to understand that this is not just hypertension, but beyond that, it's a multi-organ dysfunction. Okay, the pathophysiology is still unclear, but most theories are around abnormal placentation and immunologic factor. Normal placentation and the dysfunction causes severe maternal endothelial injury, leading to vasoconstriction and capillary leak. As a result, the patient develops multi-organ dysfunction and the uteroplacental dysfunction. So now I'm going to talk about 3 categories of disease, that is preeclampsia, eclampsia, with severe symptoms, that is called severe disease, and the third one is eclampsia. So let us look at this preeclampsia. So this is a new hypertension after 20 weeks of gestation with a systolic blood pressure of more than 140 millimeter mercury and or diastolic blood pressure more than 90 millimeter mercury with either proteinuria or maternal organ dysfunction or uteroplacental dysfunction. This preeclampsia occurs in up to 6% of pregnancies. So what if a patient already has a pre-existing hypertension? Again, so same, it's preeclampsia. The management is also going to be the same, but the terminology is different. It says chronic hypertension superimposed with preeclampsia, right? So nearly 1 in 5 pregnancies that are affected by chronic hypertension can go into preeclampsia. Okay, severe disease or preeclampsia with severe symptoms. How do we define? We look for 2 main criteria. One is blood pressure criteria and the other one is the organ dysfunction, that is organ dysfunction severe enough to cause maternal compromise or fetal compromise, right? So let's see the blood pressure target that says severe persistent blood pressure elevation either systolic blood pressure more than 160 millimeter mercury and or diastolic blood pressure more than 110 millimeter mercury, with red flags of maternal compromise or fetal compromise, so severe organ dysfunction. Right? Remember, the proteinuria may not be present. Postpartum disease also can happen, so the delivery is not going to end the problem. And so the idea is severe hypertension or red flags means severe disease. Let's look at eclampsia. So this is a pre-eclampsia complicated by seizure. That is a dangerous neurological complication of preeclampsia. So 1 to 2% of preeclampsia can progress to eclampsia. Okay, management. How are we going to manage this severe disease? So what are the ED priorities? So already we have identified the problem, identified the case. Now how are we going to stabilize? As usual, stick to the ABCD approach. Repeat the blood pressure and confirm that this is a persistent elevated hypertension, because we don't want to suddenly drop the uteroplacental blood supply. That is important for fetal well-being. Put the patient in lateral position to improve placental blood flow. IV access. Treat the blood pressure if it crosses the target. Consider magnesium sulfate as a prophylaxis to prevent seizures. Start monitoring vital signs, neurological status, urine output, fluids balance charts, and send investigation to look for organ dysfunction and urine protein. Meantime, escalate this to the multidisciplinary team, because definitive treatment is a delivery of the placenta, delivery of the baby and the placenta. So we have to give enough time for them to decide where and when that needs to be happened, right? Depending on the availability of facility. Okay, let's see how are we going to treat this severe hypertension. So when to start? As we discussed before, the blood pressure target, and the options are IV labetalol, IV hydralazines, and oral immediate release nifedipine. Depends on the availability, local protocol, and the drug's side effects, and the contraindication profile goes with the patient. So what is the main reason for treating the severe hypertension? To prevent the risk of maternal hemorrhagic stroke. Meantime, avoid rapid blood pressure reduction. We target for controlled reduction of the blood pressure. Reassess frequently. And if the blood pressure is persistently high or uncontrolled for the treatment, escalate early. That means the baby has to come out. So when do we start the treatment? The guideline says within 30 minutes to 60 minutes time. But the practice is as soon as we know that this is the persistent elevated blood pressure with the target, with the level of systolic blood pressure more than 160 and diastolic more than 110. Magnesium sulfate. So this is for seizure treatment or prevention. How does it act? Central anticonvulsant by vasodilating cerebral vessels and reduce neuronal excitability. When to start it? Eclamptic seizures, yes, as a treatment. Severe preeclampsia, as a prophylaxis, we started. The typical regime is 4 gram IV loading dose over 5 to 10 minutes, then infusion 1 gram per hour. If seizure recurs, we can go ahead with another 2 gram IV as a bolus. Monitor for toxicity, especially when there is acute renal failure, because this can get accumulated. We can use antidote calcium gluconate. So The message is magnesium for seizure prevention, antihypertensive for maternal hemorrhagic stroke prevention. Eclampsia. How are we going to treat? So any seizure after 20 weeks gestation or postpartum is eclampsia until proven otherwise. Keep that in mind. Call for help. Support as usual, airway breathing circulation, left lateral position to improve the placental circulation. Give oxygen, suck out secretion if needed. Never ever forget the glucose, right? Rule out hypoglycemia, IV access monitoring. Give IV magnesium to control the seizure and prevent the seizure. Recurrent seizures, if we can give boluses again. So if the seizure doesn't control, repeatedly going or refractory, look for other causes, right? Alternative diagnosis. So stabilize the mother first, delivery planning follows stabilization. Okay, complication. Never ever forget to actively look for this complication, eclampsia. These seizures are very short lasting and self-limiting. Patient might have had seizure at home. They may not expose or they may not tell that to us. So I had a case like that. I thought I was lucky enough to extract that piece of information from the patient family. So actively look for that. Stroke, reversible encephalopathy syndrome, pulmonary edema, HELP syndrome, DIC, acute kidney injury, placental abruption, fetal compromise. So remember, this is a multi-system emergency, not simply a high blood pressure. Common pitfalls: failure to recognize the severe disease, headache, vomiting, epigastric pain. Consider this as a non-specific symptom, missing the severe features, forgetting the postpartum preeclampsia. Failure to act, treating the new seizure as a neurologic cause or delaying the escalation. Failure to protect by giving more IV fluids and make the patient fluid overloaded. Think preeclampsia early, treat the mother before complication develop. So I would like to leave with 5 take-home messages. Recognize the severe disease early. Treat persistent elevated blood pressure more than 160 by 110 to prevent maternal hemorrhagic stroke. Prevent or treat seizure with magnesium sulfate when indicated. Protect from fluid overloading. Escalate early multidisciplinary team to plan definitive care, that is the delivery of the baby, when and where. Treat the mother, protect both lives. Thank you.
Thank you very much, Dr. Sharmila. As for our next speaker, we have another exceptional consultant emergency physician on board, Dr. Nivedan Padmanathan, who is currently working at NHSL. Dr. Nivedan is graduated from University of Peradeniya, Faculty of Medicine, achieved his MD in Emergency Medicine in 2021. He is also a member of Royal College of Emergency Medicine. He is also actively involved in global health and humanitarian medicine. He is very passionate about the art of teaching and also clinical mentorship. Dr. Nivedan will steer us through dangerous diseases in the next few minutes.
Thank you, Dhanuka, for the introduction. I've been sounding like a warped cassette player for the last few days. A gift from a friendly virus. Can't complain though. I sound much better now than what I usually do. So I thought I'll have 14 minutes of the next 15 minutes for my own to bother you with that. But as a gift, I thought 1 minute. I'll try to summarize what I'm going to say for the rest of the 14 minutes in an audio clip. Warning, please take it with a pinch of salt.
Yeah. Ticket says the room is spinning. the eyes never lie. Let's go. Bark, walking the reasons, the patient is dizzy. Try just pat, and the nurses are busy. Hold the head steady, focus the sight. Horizontal beating, darting left to the right. If it beats to one side when they're tracking your pen, it's peripheral, baby, probably be PB again. You need a rational, suppressed by the gaze. We can fix up the ear, we can navigate the maze. Essential assassin parade, pause the track, don't wait to discharge. From the danger is large. Look at the eyes, are they switching the lane? Direction changing, that's a stroke in the brain. Check for the vertical, up and down beats. If you see that, the Reaper is walking the street, tossing or twisting. The brain stems on fire, skip the CT, don't trust the nausea, don't trust the spin. Master the ends, if you wanna win. Screen cuts to black, one final text line appears. Welcome to the dangerous dizziness!
Not a pinch of salt, I would say a bucket, maybe. Okay, all right. So the rest of the body you can just leave. That's totally fine. Okay. All right, introducing our patient. We'll call her Somawati, a common name in Sri Lanka. Innocent-looking elderly from a village background with a workable IQ, I would say, coming to you with a complaint of dizziness. That's the topic. So, before you pick her up, you look at her, she's complaining of dizziness, and then your deep mind starts talking to you. And if you actively listen to it, it would say, be very careful. Do not trust her. She could eat your medical license for breakfast. She's extremely dangerous. She's a trap, rightfully so. So what do? Okay, you make your mind, there's no one else to see the patient, so you pick her up. Now what do? You get closer to her. You get closer, and now the reality hits you. You think further, what can cause this? Anything in the world can make someone dizzy. Could be things like hypoxia, hypovolemia, hypoglycemia, something in the ear. Could be anything, could be syncope, vertigo, diarrhea, stroke, I don't know what. So what happens is, all those things in reality hits at your face. Actually now, you are more dizzy than Somawati herself. What do now? Okay, I'm gonna play this safe. I'm gonna send all the blood tests I'm aware of. You send glucose, that test, troponin, everything. 2 ECGs, everything comes back normal. What do? I'm gonna play it even safer. I'm gonna order a CT. That's the only way I can make myself safe, or my medical license is in jeopardy, so we order CTs, left, right, and center. And then comes another problem. Even that is normal. Now what do? I am stuck. Thus, the whole point of my topic here. So what we need is, we need an approach. How are we going to approach these patients to make ourselves safe, limit costs for the government and the hospital that we work for, and make sure the patient is safe as well. I'll make it quick from now on, I will have 10 minutes left. Okay. To start off this approach, I would suggest, like we do day in and day out, what do you ask? You ask them, do you feel like you are spinning or your room is spinning? Do you feel lightheaded? Do you feel like your tone is lost? I would say we should stop doing that altogether. Because evidence has proven that patients change their story at least 50% of the time during each visit. And Somawati being Somawati, she will change it every 10 minutes. It's not going to work. What do? So we categorize diseases into mainly 3 categories. It could be due to a central neurological problem, or could be due to a peripheral neurological problem, or it's completely non-neurological, something completely not related to a neurological issue at all. Okay. Now, I know it's big, clustered, don't look at the slide, we'll walk it through. So we take a 3-step approach towards Somawati. The first step, we are really worried about strokes. That's the problem, and it's time critical, and we could do something about it. So what we do is, we do a complete neurological assessment in our first step. From everything, from cranial nerves to your walking, your balance, and everything. Basically your 5 Ds. Your dysmetria, diplopia, dysphagia, dysphonia. Oh God, I forgot the fifth one. But I'm pretty sure it's not dyspareunia. I'm not sure. Okay, something you could figure that out. Okay, all right. And then if you find something there, you order a CT scan, perfusion scan, whatever, and then you escalate from there. That's sorted. Okay, now step one. The step one is negative. What do? Obviously, go to step two. Step two is, okay, by the time you've gone to step two, you've taken a history, you've examined the patient, you've done the basic investigations, and if you think the soma of this dizziness is due to a non-neurological medical cause, okay, all right, that's good. I'm getting something there. Still, you pause. Rather than naming a cause to be non-neurological medical, you still take another safety net. You still look for pathological nystagmus. You look if there's any arm dysmetria, and then finally you also sit her up to make sure she's sitting up properly, then there's no ataxia while she's sitting. If any of those three are positive, any one of those, then you jump into step three, which we'll talk in detail later. Now, if step one is normal, there's no neurological signs. Step two, there's no medical causes that we could find out to fit this problem. And then we move on to step three. Usually about 2/3 of the people who are dizzy will fall into this category. Now what do? Now we assess dizziness in a different way. We do this. Every patient who falls into step three, we call them acute vestibular syndrome. Vestibular syndrome, it's because they have symptoms of vestibular, nothing else. So either these patients could have the symptoms which are episodic, and while the patient is in the ED with us, they don't have the symptoms, or the patient has an acute vestibular syndrome, which means the patient is actively symptomatic. Those episodic people who now don't have the symptoms are further categorized into two, the triggered one and the spontaneous one, which is pretty obvious, the name suggests everything. If it's triggered, obviously it's been triggered by something like usually the head movement or sitting up, standing up from a seated position. And the other one is spontaneous. So they don't know how it occurred, it just came like that and then went away. At presentation, they don't have it. The only difference between those two is that if it's spontaneous, you can't reproduce the symptoms in the emergency department. All right, now we have three: triggered episodic, triggered spontaneous, and then finally acute vestibular syndrome where the patient is spontaneous. It's not spontaneous, symptomatic at the presentation. Quick, brief description about it. If you look at the timelines, don't read this. If it's acute vestibular, it's usually, look at the timeline, it's long lasting, goes about for days. If it's spontaneous episodic, it comes and goes. It lasts a bit longer than the triggered episodic, usually hours. This slide is just to give you the idea of those things. So if you look at the acute vestibular syndrome, we are mainly trying to deal between vestibular neuritis and stroke. But it's not that simple because there could be other things. We only concentrate on strokes, but there are other conditions which can cause her to be dizzy, like could be multiple sclerosis, who knows? But can you diagnose that in the ED? I don't think so. Okay, coming back to this. Now, since we know we're going to categorize them into those three categories, so if the patient is symptomatic at the presentation, we quickly go back to that yes part, acute vestibular syndrome. We'll come to that in a minute. The other section there, now we know if they're symptomatic, they go here. So the rest are not symptomatic at this time. So episodic they are. Yeah. So we have to figure out whether it's triggered or whether it's spontaneous. What do? Simple. Our lovely Dix-Hallpike test that we do. Quick question. You do a Dix-Hallpike test on the right side, the patient becomes symptomatic, you get a horizontal unidirectional nystagmus. Diagnosis? PPPV, canal, anterior, lateral, posterior. Posterior, most of you. Unfortunately, no. If you do the Dix-Hallpike, you get a nystagmus, If it's a posterior canal, you get a peculiar type of nystagmus that you should get. It should be up tilt, torsional, not horizontal. If you see horizontal nystagmus on Dixall pike, then that is not posterior canal. If you see that, or either you see horizontal nystagmus, or if you don't see nystagmus, then you move on to see other canals. While you are doing Dixall pike, ideally you should get up tilt torsional. If you are seeing down tilt nystagmus, that directs towards an anterior canal. Then you do specific maneuvers. It's called a deep head hanging maneuver. I can't even bother to look at it. And then if it's either horizontal or no nystagmus, you move on to supine head roll test to check for the lateral canal. If the lateral canal, most of them will become positive because 30% of the patients with BPPV are lateral canals. But how many lateral canals have you diagnosed? Hardly, because you put them all into posterior canals and you do a bleed, never works. Right, if it's lateral canal, you get a specific type of nystagmus, horizontal, but it's positive on both the sides, unlike Dixall pike, where one side is positive, the other side is negative. But how do you differentiate which side is this? One side will be more symptomatic than the other side. Okay, time's running out. And then if you diagnosed horizontal canal nystagmus, you do a procedure called Gaffoni's procedure, which really works. You might have to do multiple times, but it works. Like in Epley's with posterior canal wounds. Okay, sorted. Now, if it's triggered, if you can reproduce in the ED, now it's just a matter of sorting whether it's posterior, lateral, or anterior canal, do the procedure, you sort. If it's not reproducible, then it's spontaneous. There are causes like vestibular migraine, could be posterior circulation TIA, who knows what. So depending on the clinical scenario, you escalate and do what is right for the patient. Now coming to AVS. Now what do we do? So this is when you do a HINS examination. You never do HINS on a patient who is not symptomatic and who doesn't have a spontaneous nystagmus. Because if a patient has no symptoms right now, doing HINS is it's utterly useless. You don't get anything out of it. Likewise, you do Dixall pike test who is asymptomatic who doesn't have a nystagmus. If you have a nystagmus, no point doing Dixall pike. It's going to complicate things further and it's going to confuse you further. Right, with all this basic information in place, alongside with all this information, you use something called a Stalling algorithm. Because going through this, we understand that nystagmus can give you so much information. Actually, 90% of central causes, mainly the strokes, will have oculomotor signs, more than 90%. So that's pretty damn good, I would say. So I think we need to master HINS examination, nystagmus assessing technique, and so far and so forth. And this is pretty straightforward. First, you see if there's spontaneous nystagmus. If yes, if it's directing, changing, vertical or pure torsion, central causal system. You activate go stroke. If they can't find anything, then you go escalate for an MRI and get the neurology on board. If it's direction fixed or unidirectional, then you perform the head impulse test. If it's negative, which is not good, then it's a central cause. If it's positive, that's vestibular neuritis for you then. If there is no nystagmus, then you see if you can trigger it. If you can, do a Dixall pike or a supine head roll test. So you decide whether it's anterior, lateral, or posterior. If there's no nystagmus triggered again, then there's no nystagmus. Then finally you walk the patient. If the patient can walk well, Somavati is fine and happy and walking, she's perfectly fine. Either a peripheral cause or everything's okay right now. Because all these dissipations, they could be treated by a sandwich or they might need an MRI. So figuring that out takes a lot of clinical expertise. And then that's, yeah, thank you.
Dr. Nivedan, thank you very much for that informative talk. So, as the next speaker, I would like to invite Rajapaksa Mudiyanselage Amita Dinendra, consultant emergency physician from Teaching Hospital, Kurunegala. Amila obtained his MBBS degree from University of Colombo, and he got his diploma in critical care medicine in 2016, and he completed his MD emergency medicine and MRCM in 2022. So he is going to talk today on acute vision loss, a time critical emergency. So over to you, Amila.
Okay, good afternoon everyone. Thank you Dr. Raj for your kind introduction. So my topic is acute vision loss, a time critical emergency. So first I'm going to walk you through these objectives. First, I'm going to talk about etiology and impact and the 5-step approach to diagnose and manage acute vision loss. Then critical action which can be taken in the emergency department, and then advanced tool, mainly focusing on use of portable tonometry and focus. Okay, regarding global impact, so this is actually presentation wise, there's around 2% presentation to the emergency department. Not significant proportion of patients are presenting with acute vision loss, but issue is they can have around 15 among them, they can have 15% patients can have systemic presentations, and misdiagnosed rate is as high as 25%. So 1 in 4 patients likely to be misdiagnosed. That is the main issue with acute vision loss. So I know you have seen this image from the medical schools, so I'm not going to talk about that. So let's talk about anatomical etiologies. If you can divide these conditions into these etiologies, pre-retinal, retinal, post-retinal, and central causes, that would be very easy to diagnose these causes in the emergency department. So pre-retinal causes, especially you need to suspect corneal pathologies and acute tangle closure glaucoma. Retinal, obviously central retinal artery occlusions, central retinal venous occlusions, retinal detachment, and hemorrhages. Then post-retinal, optic neuritis and the ischemic optic neuropathy. It could be anterior or it could be posterior. Of course, central causes, you can't miss strokes and also tumors and like pituitary and other tumors and the pituitary apoplexy as well. So now I'm going to discuss about the 5-step approach. So first step is to determine the laterality. See whether the patient is having monocular vision loss or binocular. So if it is monocular, it is pathology is more likely to be anterior to the optic chiasma. So focus on the mainly on the globe and the optic nerve. So if it is binocular, it is posterior to the chiasma. Think about the strokes and the cortical pathologies. These patients present with acute vision loss in one eye. Check the other eye as well. So second step is to assess the pain. You know that you can check whether it is a painful or painless. Then you need to assess the temporal relationship, whether it is a sudden loss or whether it is a subacute. So then you can narrow down your diagnosis. So when it is sudden, you need to suspect vascular causes, especially central retinal artery occlusions or amaurosis fugax. If it is subacute, you can suspect inflammatory causes, infectious causes like optic neuritis, acute tangle closure glaucoma. So if the patient pain is worsened with the movements, you can suspect optic nerve sheath involvement. In step 3, you also need to take a focus history regarding risk factors and the progressions of the condition. So next step is most important one, the target examination. Okay, so we need to check visual acuity, you need to check the pupillary reflexes, you need to check the visual fields, and you need to check the IOP measurements, and also you can go ahead with focus ocular, especially for screen the posterior chamber. So step 5 is actually from this history examination, you can make a diagnosis and act accordingly and make immediate, especially if it is ophthalmological, you can make referrals, and then if it is stroke, you need to consult with your neurology team. Okay, so the ocular, the visual acuity is considered as ocular vital signs. Okay, if the vision is 20 to 100, that means you are legally blind. Okay, so if the vision is very impaired, you can follow this sequence of this sequence. So you can go ahead with checking the count fingers, hand motions, and light perception. Another very important diagnostic test is relative afferent pupillary defects. So I'm not going to talk about this, but you should be very familiarized with this test when you are seeing and managing patient in the emergency department. So then visual field, it is very important to do the visual field test. So you can identify whether the patient is having hemianopia or whether the patient having altitudinal defects. That means whether the patient has lost upper or lower part of the visual fields. So in that case, you can suspect localized lesions like localized detachment or ischemic optic neuropathy. See, if it is hemianopia, it could be more likely stroke or tumor. So what do you think? Using the ophthalmoscope in the emergency department, is it easy? So usually, sometimes you might be having difficulties in examining the fundus. So especially when patients are having problems with past surgery, and also when patient is having small pupils. But you can compensate for that with focus. But it is not completely replacing the ophthalmoscopy. You need to be familiar with doing ophthalmoscopy. So now I'm going to discuss about a few conditions which are very important in emergency department. So as you see this picture, diagnosis is clear. So you can see the red dye with hazy cornea and mid-dilated fixed pupil. Patient may be presented with nausea, vomiting, severe eye pain. So you can measure the IOP. So you can start the treatment. But problem is, if you are treating this as infection, it is going to be a huge mistake to the patient, and it could lead to permanent visual loss. So try to measure the IOP in the emergency department, or take the help from the ophthalmology team if it is not present in the emergency department in where you work. So these are the numbers in acute angle glaucoma. So I'm not going to talk about management of these patients. So you know the management. So you can start with topical treatments, then go ahead with the IV and the osmotic therapy and all those things. So try to use, if it is available, it is very handy in the emergency department, that is tonometry. No need of any anesthetics, local anesthetics, so you can measure and monitor the IOP in the emergency department. So then next, what you can see in here. So you can see the pale retina, and you can see the spot there. So that so diagnosis is central retinal artery occlusion. So problem here is, even though you diagnose, so you should actually, there is there are research and trials ongoing regarding this retinal artery occlusion. So when you see these patients, you need to activate stroke protocol according to new guidelines. So there is a possibility of using IV or intraarterial thrombolytics, but it is not universally standard treatment currently. So I will discuss it later. So there is a meta-analysis done regarding central artery occlusions. So it suggests retinal infarction can occur within 12 to 5 minutes. So it is in the very early periods, retinal infarction occurs. So nevertheless, you can start your treatment because most of these cases are incomplete. So they will benefit from your treatment, which you are currently using, practicing in your emergency department. The revision trial is ongoing. So this will produce more information on how to use IV thrombolytics for central retinal artery occlusion in the future. So be alert on that. So next I'm going to talk about orbital compartment syndrome. So if the patient presented trauma and severe trauma to the face and restricted eye movements and very hard globe, so you need to suspect orbital compartment syndrome. In this situation, you don't need to wait for CT to diagnose. It is a clinical diagnosis. You can go ahead with what is called lateral canthotomy with cantholysis. So actually this is a high acuity, but low frequency presentations. You have to be prepared for this. So little bit about how to do it. So this is the anatomy. So you can if the patient is conscious, actually you can take the consent, and if the patient needs sedation, you can sedate the patient. So you can give local anesthetics with adrenaline, lidocaine with adrenaline, then apply clamp for 1 minute to reduce the bleeding, then go ahead with the canthotomy. And if usually you can also cut the inferior crust and see whether the eye mobility is increasing and IOP is dropping. If it is mobility is not improving and IOP is not dropping, you can go ahead and do the superior catholysis as well. This is regarding clinical pulse. So you can suspect if there is sudden binocular vision loss, stroke, you should be suspected stroke. So always check the good. You can if you are having difficulty in doing focus examinations, always compare with the normal line. So then you can get more information regarding ultrasound findings. So better to take a IOP baseline measurements, especially painful red eye conditions. So there is a place for point of care ultrasound in retinal detachment. So you can see seagull signs, and also in vitreous hemorrhage, you can see washing machine signs, especially when eye movements. You can see debris are moving with eye movements. Also, you can measure the optic nerve diameter if you are concerning increased ICP. So new AD standard. So you can do structured assessment as I discussed, 5-step approach. You can do the focus and do the portable tonometry. So make sure the time is vision. So take home message, always think about ocular stroke, master the focus, and regarding giant cell arteritis, don't wait for biopsy, just start treatment with steroid. So references, Yes, thank you very much for listening.
Thank you very much, Dr. Amila. So we are coming to the end of this symposium. There are few minutes left for any other questions that you want to ask from our panel. So, since there are no questions from the audience, I would like to ask a small question. Are there any contraindications for lateral canthotomy?
Yes, if there's a globe puncture, there's a globe injury, so you can't do the lateral canthotomy. But if you are suspecting like orbital compartment syndrome, if the vision is severely impaired, it case by case, you can go ahead with the lateral canthotomy, but it's a senior decision. Generally considered, it is a contraindication. If there is a globe injury, it is penetrating injury, it is contraindication for canthotomy.
Thank you, Dr. Amila. So with that, we are concluding this symposium. So thank you very much. So with that, I think, yeah.
As we conclude this symposium, I would like to express our sincere appreciation to our speakers for sharing their expertise and valuable clinical experience with us today. I would also like to extend our heartfelt gratitude to chairs for facilitating the discussion. May I now invite our chairs, Dr. Viraj Rajapaksha and Dr. Dhanuka Senaviratna, to present the token of appreciation to our speakers. Dr. Viraj Rajapaksha, please come forward to present the token of appreciation to Dr. Achala Galiyadda and Dr. Shamila Prashant. Dr. Dhanuka Senaviratna to present to Dr. Nivedan Padmanathan and Dr. Amila Dinendra. Thank you, everyone. This brings us to the end of Symposium 4 and the scientific program for the day. I have few messages from the organizing committee. The candidates who are selected for the MRChem Speed Mentoring Program, please be present by 7:15 a.m. tomorrow at the Orchid Hall, which is at the back of the main conference hall. This event, the MRChem Speed Mentoring event, will provide an amazing opportunity for all the participants to get the first-hand experience and information from the actual examiners and question formulators of the MRChem. So congratulations to all participants, and I will now repeat the names of the participants. Dr. VG Marisha Fernando, Dr. Metmal Malavarachi, Dr. Mahendra Raja, Dr. Srizana, Dr. Vidura Miranda, Dr. Nadisha Ushani, Dr. Pasindu Prabodh, Dr. Madhushankar Suryarachi, Dr. Shakila Kumari, Dr. GLS Amanda, Dr. Gayani Nirmala, Dr. Karunaratna, Dr. D.S.E. Veerasinghe, Dr. Kadugat, Dr. Ahmad N. Ali, Dr. Yoganathan Gauri Nesan, Dr. Lakshita Vijayawanta, Dr. Y.N. Rajapaksha, Dr. Nazat, Dr. Giguruva Kamage, Dr. KTP Priyadarshini, Dr. Deheragoda, Dr. Lakshika Delvatta, Dr. Tharindu Vidana Gamachi, and Dr. Nuwani Kumarage. Another small message. The delegates who have not collected their care packages, which includes a tote bag, a traditional ceramic water bottle, and stationery items, please collect them at the registration desk. Thank you.